Welcome to our podcast, Psychiatric Services, From Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with podcast editor and my co-host, Josh Berezin. Hey, Josh.
Hey, Lisa.
Today, we're not going to talk about 3 articles.
We're going to talk about one article and not by ourselves.
There we go. That'll probably be a big relief to our listeners. We are going to be interviewing Dror Ben-Zeev, who published an article this month on mHealth.
Yeah, and it's we think it's a good conversation and a really interesting article, so we hope you enjoy.
Here we go.
We're very excited to welcome Dror Ben-Zeev, who is a professor of psychiatry and behavioral sciences at the University of Washington School of Medicine, to the podcast. Welcome, Dror.
Hi, Josh. Hi, Lisa. It's lovely to chat with you.
Yeah, and so we're going to be talking about your article, Mobile Health, mHealth versus Clinic-Based Group Intervention for People with Serious Mental Illness, a randomized controlled trial.
Yeah, and we're very excited to do our second author interview. We're very glad to have you, Dror.
So before we get into the article, Dror, I was hoping you could just give us a little bit of sense of how you got interested in this research, how you got involved, what sort of sparked your interest in mobile health.
Sure. Well, it's actually quite an interesting story because I landed on mobile health almost accidentally. I'm a clinical psychologist by training. And at some point in graduate school, when I was trying to figure out what would constitute interesting research for my master's and my doctoral dissertation, I came across data collection strategies that use mobile technologies called experience sampling methodology, or ESM. The idea there is that you give someone, a research participant, a mobile device. Back then it was either beepers or Palm Pilots.
Pilots, I can't, that's a real blast from the past.
Older than beepers? Well. Beepers is like...
So, and it's not that cell phones were not around back then, but really they weren't integrated into research in the way that they were today. But the idea is that instead of asking someone in a clinic or in a clinical research setting to retrospectively try to give you an estimate of how they think and feel and function throughout the week, because that's so prone for a bias and a host of other variables that might affect what your response might look like, the mobile device is carried with them wherever they go, and it prompts them multiple times throughout the day to complete these in-the-moment self-assessments. And so the idea is to try to get multiple snapshots of someone's life that later on connect to this more vivid film rather than one retrospective estimate. That was the premise of this kind of research.
So you really came to this from the research side of things rather than the clinical side of things?
Oh, absolutely. So earlier on in our studies, the intention was not to try to help anyone. It was really just
God forbid.
of being this unobtrusive fly on the wall that gets multiple opportunities to just observe how people are thinking and feeling and functioning. But then when people would return the devices at the end of the data collection period, something really, really interesting happened. Aside from getting interesting data, which was the objective of the study, the folks in the clinical samples would often say things like, "Thanks, doc, this really helped me."
Huh.
And again, it was really startling because there was no plan to help anyone at that point. But time and time again, they kept saying things like, "Thanks for checking in with me multiple times throughout the day," even though it was clear that it was software, right? There wasn't a person checking in with anyone. But that experience of something or someone asking people to take a beat and introspect for a moment and examine how they're thinking, what they're feeling, what they're doing, time and time again, was both illuminating on one hand and really gave the sense that someone is caring for them.
Was that surprising to you that people were interacting with technology in that way, and that what you might have thought of as a drawback, that it didn't have like a real human on the other side of the beeper, let's say, or the phone, was actually turning into something that people liked or found useful?
Oh, it was totally surprising to me and unexpected. I'm naturally at baseline. I'm quite technophobic myself, and so
well, if people saw what went into getting us to be able to record the interview, they'd realize they were also a little technophobic as well. But
right.
sorry,
So
go ahead.
this isn't a group of people who are naturally inclined in these areas, or at least back then I wasn't, and so. I was drawn to the field of clinical psychology because I believe in human connection, right? And so this idea that something seemingly so powerful can happen with someone interacting with software where there isn't another person on the other end there was really quite interesting. We're getting these anecdotal outcomes where people are describing feeling better just because of answering several questions throughout their day. What happens if we actually put our minds to it? And so flash forward, I suppose close to 16 years now, that's really most of my research is now devoted to mobile health, leveraging technologies for assessment and ideally treatment of people with mental health conditions.
Terrific. That's such a great way to start, Dror. Perhaps we can have you just briefly summarize the methodology of your study and the questions you were asking.
So the study was a comparative effectiveness trial. It was a randomized controlled trial comparing two interventions. Both are designed to improve illness management and support recovery in people with serious mental illness. One was clinic-based care, an intervention called WRAP, or Wellness Recovery Action Planning, which is a widely used evidence-based intervention that has been demonstrated to be effective among people with serious mental illness. It's conducted and led by two facilitators with lived experience, and it's what you typically think of when you think of a group intervention conducted at a clinic, right? Groups are anywhere between 6 to 10 people. Meetings last anywhere between 90 minutes to 2 hours, and people bring in their experience from illness, but also there's the social aspect to this, right? That there's this group of people that are invested in each other and all that entails. The other intervention is a mobile health intervention called Focus, which is entirely delivered by a smartphone. And so there's a Focus app, which is installed on the smartphone that provides prompts multiple times throughout the day for people to respond to questions. And then based on their responses, they will get treatment content that can come in the form of either written interventions on the smartphone screen or videos and audios of clinicians or actors either demonstrating self-management techniques or talking them through coping strategies.
Can you just give like an example of what just one of those modules might look like?
So I think the video that's on the Psychiatric Services website actually demonstrates one of the interventions. We might ask someone, or Focus might ask someone, if they've been struggling with voices today. And if they say yes, it'll follow up with an assessment of the beliefs that they might have about those voices. They're all-knowing, they're powerful, they're a product of my illness, and so on and so forth. So if someone endorses feeling that the voices know everything, an intervention is a video. It actually depicts me saying voices don't know everything, and you can try certain strategies to test whether they in fact have all the answers. So ask them to make a prediction about the color of the next 3 cars that you see in the street and write down the order that the voices say for those colors. Now test it, right? And so it's a form of evidence gathering, right? We give people these tools to test whether their assumptions about the voices, whether they're powerful, whether they're all-knowing, whether that's accurate or not. And the idea is that gradually we start chiseling away at some beliefs that in some cases people have held for decades, right? And so if the voices got the order of the cars wrong, what else could they be getting wrong in your life? And so the strength and the power of the voices gradually diminishes.
And there is, though, also, that's all automated, correct?
That's right.
But there is also some human aspect to it as well, with people following up?
Right, and that's I think a very important point, that mobile health doesn't mean just an app, and it's certainly not the way that we deployed this, right? So Focus, the app, is the primary resource in this intervention, but there's also a person in the loop. So there's a mobile health specialist, someone who's actually embedded at the community agency where we conducted the study, and they will meet with the individual for that first meeting where they train them how to use the app, and in some cases even how to use the smartphone touchscreen, right? So basic technical training. But later on throughout the study, the mobile health specialist would call someone weekly for a phone chat that's anywhere between 5 and 10 minutes. First of all, to see whether there's any technical need, right? Whether they can provide some sort of technical troubleshooting and all the phone functions and app functions are working well. But then once that's overcome, and if people are not having trouble, they would also help take the more general suggestions and coping strategies that the app would deploy and try help individual users translate this to their day-to-day experience. So let's say if it's a relaxation strategy and someone doesn't know how to integrate this into their day-to-day life, the mobile health specialist would use examples drawn from those conversations. So if someone gets especially anxious talking to their sibling, they would say they would work them through a plan where maybe they would deploy relaxation strategies 10 minutes preceding that meeting with their sibling. So they would really help anchor and tailor it to their day-to-day life.
That's great, Dror. And I actually wanted to ask you, or perhaps underscore a point, that the strategies that are embedded in the app and that clearly the mobile health specialist follows up on are not anything necessarily that you invented. They're cognitive restructuring, variety of well-accepted techniques, but what's very cool about it is that you adapted them, it seems to me, for this focus environment. Did I understand that correctly?
Yes, that's correct. I mean, I think we didn't necessarily draw verbatim the wording from existing interventions, but the principles and techniques are certainly based on existing models of intervention. Our adaptation is one to try to get to the point quickly, right? Mm-hmm. Because whether it's a sequence of screens or a video, people are not interested in watching a 15-minute video of someone describing something in an elaborate way, right? So the idea is get to the point and get to the demonstration and try to crunch it all within 20 to 40 seconds, right? That was our objective, is to keep every intervention less than a minute to read or to view. And we really accomplished that. And so I think it's very similar to those kinds of interventions. It's just distilled. And the idea is also to not provide just a general lesson, but really try to encourage people to use the technique right then and there on the spot, which is a little bit different from the kind of training that you might get in a session where it's more didactic in nature, where you're exposed to the intervention, but then we expect people to think on their own when to deploy it. With focus, often we'll encourage them to take a moment and do it right now.
And so getting back to the study, like you mentioned, this is a comparative effectiveness study. What outcomes were you looking at, just generally speaking?
So we were looking at three broad outcome groups. The first one is treatment commencement and engagement, right? Regardless of whether the interventions work, are we even able to get people to the clinic, and are we able to get people to engage in mobile health? The second group was satisfaction. At the end of treatment, are there differences in their subjective experience of the treatment model? And the third were clinical outcomes, and those are the typical clinical outcomes that you might see in a study like this. So reduction in symptoms, quality of life, and recovery.
And what's the big take home from your results?
I'd say that there are two big take homes. The first, before we even get to the clinical effectiveness of this, is the dramatic difference that we found in treatment commencement and engagement in both interventions. And so it's a randomized controlled trial. So once people complete their baseline assessment, they're informed which one of the two interventions they're going to. And the first thing that we measure is, do they follow up? Right? Do they wind up meeting with an ML support specialist, getting introduced to the app and use it at least once? And in the other arm, do they connect with their RAP facilitator and ever make it to a single RAP session, right? Do they start care at all? And right then and there, we see that 90% of the people who were assigned to the mobile health intervention actually went on to use it at least once, whereas only 58% of people assigned to RAP ever make it to the clinic. And so we're losing over 40% of our sample here right off the bat when we asked them to come to the clinic and to engage in that type of format. So that was really eye-opening for us. The second main outcome was that in terms of clinical effectiveness, we could not distinguish between these two interventions. There were no significant differences between them. Both of them produced improvements on the outcome variables, but the magnitude of change in both of them was very, very similar. And so there was no difference between both interventions. Both seemed to have positive impact on our participants in the same way. But if we're trying to draw conclusions here that are more at the principle level and they're potentially generalizable, I'd really focus on this idea of treatment commencement, right? Because regardless, when people make that decision of coming to the clinic or not, or engaging in the mobile health intervention or not, they haven't had any exposure to treatment content one way or the other. So this would really be relevant to any clinic-based group intervention and any mobile health intervention that's assigned to them. And so again, we see that close to half of the people that were assigned to the clinic-based format never show up at all. And so that, in my mind, is really the important piece here, that just the modality, before we even talk about content and potency of the intervention, the modality on its own is something that is really new. We just haven't explored these things systematically in this way, and for the first time, we're seeing how they really match up when they go toe-to-toe against each other.
And this is such a great, you can really see the importance of a randomized trial here, because we have every reason to believe that these two groups are reasonably equivalent.
So one other question I had was, if you think that this intervention is going to be really picked up by a younger generation of clients, your sample was about 50 years old, I think, if I'm reading it correctly. And I just wonder if people who grew up using this technology, using smartphones and FaceTime and Facebook, might have a different, or might even be more open to this sort of intervention.
Well, so that's a good question, and I think it's a testable one, right? I mean, I think that on the one hand, we can assume that people that are digital natives who are much more comfortable dating online, shopping online, banking online, would be much more comfortable with accessing mental health care online as well, right? Using their mobile device, which they probably use for every other function in their life. At the same time, though, these are also, I think that in terms of engaging these participants, the bar for technological innovation, meaning how impressed are they going to be by a self-management app, and how long will they engage with this when they're exposed to smartphone games that frankly will blow, in terms of the user interface and the intrinsic interest, will blow something like Focus or any intervention app out of the water. And so we might also be able to engage with the novelty of this, a population that is less familiar with all the smartphone functions and might be a little bit older. And that's actually supported by an earlier study that we conducted with Focus. We deployed Focus as part of this multimodal relapse prevention program that was deployed in 8 states. And it was an earlier version of Focus that didn't have video. We specifically looked at engagement as the outcome. And we actually found that younger participants, meaning age 18 to 29, had less days of on-demand use during the week than participants that were older, 30 to 45.
It's fascinating.
Do you think that it may have been in some ways more novel for the older people?
It could have been more novel. It could have been, well, the patterns, the demographic patterns that predicted engagement in our study with mobile health were identical to the kinds of things that we see regarding engagement in psychosocial interventions in person. So in terms of the racial composition, in terms of the breakdown between males and females and younger participants and older participants, the patterns were identical to what we would see from psychosocial interventions. So it could just be that younger participants are more difficult to engage in care, regardless of whether it's a digital intervention or not.
Do you feel like we're kind of on the curve, behind the curve, ahead of the curve in terms of keeping up with technology and some of its potential uses in mental health?
Well, I think we need to separate between the clinical research and what's happening in practice, right? So in terms of the clinical research, I would actually say that the use of mobile health interventions in the mental health space is cutting edge. I think that we're not necessarily, like we see in other areas of psychiatry or psychiatric rehabilitation program, the research often is late to show to the party, right? Where we start using interventions and modalities after they've been deployed extensively in other areas of medicine. Here we see that we're trying things like self-management apps and audio and video-based interventions and multimodal sensing interventions and predictive modeling and all these sort of fancy new mobile health and e-health approaches for the first time with these populations with mental health problems. And so there, I think that the research is on par, or if not at the cutting edge of mobile health research, what we're seeing in mental health. When it comes to practice, of course, this is a different story. I think that, one, the translation from research to practice, the delays that we see across the board, I think that they seem to apply to the mobile health world as well, because we're all trying to figure out how do we actually take this from research to practice. The technology is moving so quickly, the platforms are changing, the software capabilities are moving forward, and that's largely driven by the commercial world, right? We're leveraging the resources that exist, that are generated by companies like Apple and Google, right, that help push things forward. How does the FDA or other regulatory entity, how do they certify whether an app is appropriate for use or not? How do we deploy this in the context of HIPAA requirements, the regulatory standards, the agencies, the healthcare systems really don't know quite yet what to do with all of this and how to integrate this into the workflow and to do it in a way that on the one hand is secure and safe, but on the other hand is not so late in the game that by the time we're actually able to deploy this, the technology is not irrelevant because we've moved decades ahead with a new technology. So I think there's a real tension there between what we're doing in research and able to demonstrate there and what might wind up actually in the hands of patients anytime soon.
Is there anything, Dror, that you'd like to highlight that you think doesn't come through in the article or that we haven't really spoken about to this point?
Well, I think that the article ends talking a little bit about what the next steps are. The area we're gaining more and more evidence in this area of mobile health, and focus is one of many promising interventions. I think we're going to see many more outcomes from trials that are coming to conclusion in the years ahead. I think it's clear that some of those mobile health interventions are going to be clinically potent and helpful. That's a given. Now, the question is, how do we make sure that these interventions do not just stay in the research domain? And so questions pertaining to real-world implementation and application of these, those I think are the most interesting questions that are just over the horizon. How do we actually integrate this into real world practice?
So from the mobile, from the phone or the app to practice. Our podcast is pages to practice, and maybe we need to move forward and think about from
podcast to practice.
There we go. Dror, thank you so much for talking with us today.
Yeah, this was great and just a very interesting, thought-provoking article to read. So we definitely encourage people to check it out.
Yep.
Oh, thanks to you both. I appreciate it.
So that's it for today's podcast. We invite you to visit our website, ps.psychiatryonline.org, to read the article we discussed in this episode, as well as other great research. And you can also find the demo that Dror referred to on the website. We also welcome your feedback. Please email us at psjournal@psych.org. You can also rate and review the podcast on iTunes, Stitcher, or wherever you listen to it. I'm Lisa Dixon.
I'm Josh Berezin.
Thank you for listening. We'll talk to you next time.